Hi, good evening. My name is Monique Hill, and I'd like to welcome you to tonight's webinar. It's brought to you by Texas Fertility Center, and the topic today is your first fertility evaluation. I'm so glad that you're able to join us. We are joined today, our guest speaker is Dr. Allison Petrini. You can find more information about Dr. Petrini on the website and also about upcoming webinars. The website is txfertility.com. Sometimes it's a little tongue twister, txfertility.com. And she is actually highlighted on the landing page, on the home page, because she's new to Texas Fertility, not to fertility, but she moved recently down here from Austin. She is a native Texan, but she actually moved from New York City. So she survived COVID in New York City. So that just tells you how resilient and strong she is. So we're really excited you're here. We have these webinars the third Thursday of every month. The next webinar in September is going to be treatment for PCOS. And then the October webinar is going to be Fertility 101. So we'd love for you to join the webinars, any future events, or share information with your friends. This is an amazing way to get information on fertility, to be able to talk to a doctor, to be able to ask questions and not have to pay a copay or spend an hour or more of your time. So I just really encourage you to share these events with anybody you think might be interested and to also attend future events. As a little administrative information, we welcome your questions. You'll see on your screen there's a spot on the top right-hand side where you can ask questions. If you press the questions button, you can submit your questions online. We will stop about halfway through to ask Dr. Petrini some questions. I'll come back on and field those questions for you. Then she'll finish up with a little bit more information on what to prepare for your first visit. And then at the end, I'll come back on to finish asking more questions that you may have. And then we will wrap it up around 7:15 or so. I do want you to know that your questions are confidential. So please do not worry that anybody's going to have your information and see what the questions are that you've asked. So feel free to ask anything that you'd like to, and we'll try to get to as many questions as we can before the end of the session. So that's enough of me. At this point, let's get Dr. Petrini on, and I will see you about halfway through to answer some of your questions or to ask your questions. So for now, here is Dr. Petrini.
Hi, everyone. Thank you so much for joining. I'm Allison Petrini. I'm one of the new physicians at Texas Fertility Center. And I'm so glad you guys are all on. This is a really great way to gather information. And as Monique said, it's really great because all of your questions are anonymous. So you don't have to be embarrassed to ask anything. It's just an open forum that you can get your information. And I think one of the first steps, even before you come to the office, is deciding to come to the office, and having something like this where you know what to expect will also kind of get you over that hump of feeling uncertain or not knowing what to expect when you get there. And knowledge is ultimately power. So showing up will be a little less scary if you have an idea of what it's going to look like. So I'm just going to kind of talk through what you would expect before, during, and after your first fertility visit. And so we'll start with some of the things from before and during, and then I'll have Monique come back on and we can answer questions at that point. And then we'll talk about some of the things that we might find out from some of the workup we recommend at the initial visit. So first, to start talking, when you first call the clinic to schedule an appointment, one of the major things that we can find out at that time for you that will help you address your needs coming in is we will gather insurance information, because a lot of people have questions about what exactly will be covered when they come for their visit. And it's actually interesting that a lot of times fertility evaluations, or the testing that we do, is actually covered by insurance. So that is actually a big weight off of people's shoulders when they know that where they're going to stand and what kind of things that they could expect walking in. So we can gather that information up front, get you some information and what to expect from that standpoint. So then coming to the visit, a lot of people have different reasons why they decide to come see us. So it could be that you've been trying to conceive for a really long time, or maybe you just have an inkling that you're going to need help. So maybe your partner has had a vasectomy before, maybe your periods have always been irregular, maybe you're in a couple and you just need our help matching with a sperm or an egg. There's so many reasons why people come to see us. But all of those reasons together mean that you might come in with a different level of understanding or a different level of knowledge about what's going to happen when you get there. And a lot of people have prior infertility workup that has been done by their OBGYN. A lot of people have talked to friends about their experiences. And it's important to know that every single couple or person coming into our office, we're gathering very individual information. So not everyone's visit or everyone's journey is going to look the same. So the first visit is about 90% talking. So when you come in, we're going to be gathering extensive information about you. We want to get to know you, who you are, and you want to get to know us so that you can see that we are people who are going to be alongside you during this process and this goal. But ultimately, we also need to get very factual information. And some of these things surround what your goals are as far as your family building goals. And then some of these things have to do with medical conditions. So for instance, we would start taking a full history of you and your partner or whoever is going to be in the journey with you. And initially, we just want to know, how long have you been trying? Or what are your goals? How many children would you like? Things like that. And then ultimately, we're going to ask about a detailed menstrual history. Have your periods always been regular? Have you noticed irregularities there? Have you had pain? And part of the reason we do these detailed histories is not to torture you or to make you pull out your menstrual calendar from your phone, but a lot of that can give us information on what might be going on that has caused you to have to see us to begin with. So after we get a full menstrual history, talk about, have you used ovulation kits? Have you had something called a history of Pinkogram, which I'll explain a little bit later. We're also going to talk about prior pregnancy history, if you've had history of loss before, as well as what types of infertility treatments you may have gone through already. So all of this will come together and start giving us an individualized picture of where you have been and where you'd like to be going. And then the second half of the history is really to get an idea of your surgical history and your medical history. Are there things that could interact to not only cause problems with infertility, but make it so that we need to do something to optimize a future pregnancy? For instance, some people have medical conditions that we need to look into and make sure they're healthy. Sometimes there are endocrine disturbances that cause infertility, and we can check those out as well. Sometimes people have had a history of surgery. For instance, if you had a ruptured appendix, we might think that you have scar tissue in the abdomen that could be causing infertility and not allowing the tubes to pick up the egg. So all of that in the history is almost as important as some of the tests that we do. So other than your surgical and medical histories, we also talk about environmental exposures, some toxins that you might be exposed to, and then how much caffeine are you having? How much alcohol are you drinking? What's your exercise look like? And really lifestyle factors. We also talk about family histories, whether there's been any history of genetic disease, because we are in a unique position to be able to intervene and do something. If there is a genetic issue that has been going on in your family history, we might be able to prevent a bad outcome for you in the future. So we have some technologies that are really incredible. So after we get a full history for the patient, we will often also take a full history for the partner if they're going to be part of the process. So basically that would look things like, has the partner had a semen analysis before? Have they seen a urologist? Has there ever been any history of male surgery? And sometimes these things pop out that no one has thought about, that this could affect their fertility. And we find and pick up things along the way. So we'll look into basically all of those histories. Usually, after having taken a history, we can kind of get an idea. Are there red flags? Are there things we should look into further? And the initial fertility visit will give us a full picture of that and give us an idea of what types of tests we want to do going forward. So there are some basic tests, which I'll talk about in a second, but sometimes we also customize these tests in order to elucidate further some of the things that came up in the history. So after we have a full history taken, that's basically going to be 80 to 90% of the visit. So if your visit is 45 minutes or an hour, we'll basically talk for 30 minutes or 45 minutes. And you should have a really good sense of, what we're looking for. I'll have a sense of what you're looking for in a doctor and a patient relationship. And so we can go forward making the best decisions that fit your goals, your needs, and also where you've already been medically. So after that, we will also have a physical exam. So just like if you went to the cardiologist and they're going to listen to your heart, we're gynecologists. So we have a way that we can look at the pelvic structures, namely the tubes, ovaries, and uterus. So we would like to do an ultrasound. And this is actually one of the things that's sometimes anxiety provoking for people at their first visit, because many people haven't had a vaginal ultrasound before. But that's really our best way of looking at the pelvic organs. So we do a vaginal ultrasound, and it can give us a really good picture of the uterus and ovaries. So the reason we're doing this is because it's one of the most basic tests to start looking into factors that cause infertility. If we look at the uterus, we can take a look at if it's a normal shape, whether it has growths like fibroids or polyps. And then we can also get an understanding on the ultrasound of what your ovaries look like. Are there cysts or abnormalities that could be causing infertility? Could you have cysts that are a sign of something called endometriosis? And in addition, the ultrasound of the ovaries can also give us a good idea of what's called your ovarian reserve, which we will go into a little bit more later. I'm sure many people have tons of questions about. But ovarian reserve basically means how many eggs do you have? And we can see that on an ultrasound in the right portion of the cycle. So this is part of the very basic work that we do. In addition to the ultrasound and the full history, the other things that are a little bit more variable based on the history that we elucidate are the other fertility tests. So for instance, blood work is a big part of something that we would do an initial evaluation on. So I know some people probably have questions about blood work, and I would love to go into detailed specifics of that. Some of the things that we send on everyone at the first fertility visit and that we talk about is that AMH level, which is the ovarian reserve testing. That's anti-Mullerian hormone. In addition, we'll talk about sending things like your thyroid level and something called prolactin. And both of those just help regulate the menstrual cycle. In addition, we look at them to make sure that there's no thyroid disease that could be affecting a future pregnancy. So in addition to those, sometimes we'll send an A1C, which tells us how well the body is tolerating glucose or sugar in your blood. And then we'll usually send other tests that depend on the history we find. For instance, if you have a history of pregnancy loss, we might find other tests useful. If you have a history of irregular periods, we might find other tests useful, like your androgen levels, things like testosterone, for instance. So outside of the blood work, which I would love to answer specific questions on, we've had the ultrasound, we have the blood work. The third test we like to do is something called an HSG, or hysterosalpingogram, and that other people may call it an X-ray dye test of the fallopian tubes. So the ultrasound can give us a good idea of the uterus and ovaries, but actually doesn't give us a great picture of the fallopian tubes. And those tubes are important because they're the highway where the egg goes from the ovary to where it will meet the sperm and eventually to implant an embryo into the uterus. So we usually do this with a radiologist to look to see if those tubes are open. So that's something we would talk about and send you for after the visit. And then the fourth test, I always laugh that women have 3 tests, the male only has 1 test, and that is a semen analysis. So the semen analysis gives us an idea of if there's any male factor contribution, which about 30% of couples will have. So it's a really important piece of the workup. So basically with those 4 tests, the ultrasound, the blood work, the HSG, and the semen analysis, we can begin to get a really good picture of what's going on, in addition to your history, to more understand to understand more individually what's been going on. So the final thing that I always talk to people about in their first fertility visit is something called genetic carrier screening. So this is something that your general OBGYN may have already done, but basically the idea is that we want to talk to you about genetic recessive traits that could potentially affect a future pregnancy and make sure that you and your partner, if you are carrying the same recessive trait, that those don't end up matching up. So those are the main tests we talk about in a basic infertility visit. So I think we have some questions here that are more specific. So if I can, I'll bring Monique back on. We'll go through those, and then I'll talk about some of the things we might find when we get some of these tests back.
Perfect. One question is, what are things I should look for in finding a fertility doctor? Do you have any advice on, how to match up a person with a fertility doctor?
Yeah, so I think that's a really great question. And obviously, being in this field, friends ask me all the time who they should go see. And having both practiced in New York and now in Texas, I know a lot of different doctors. And I think that you'll see sometimes that people specialize in certain things on their bios, on their websites, for instance, which is actually a good way because that means those people have a special interest and may have special knowledge in those areas. So you could always match yourself up that way. But I also think it's really important that if you pick someone based on their bio, what you think they are interested in or where their training has been, that once you go to that visit, it's really a personality match. So if my friends ask me who they should see, I try to match them by who I know will be a good kind of partner in this process, because many people are in this process or in this journey for a really long time, really long, in this day where we want everything now. Doesn't have to be an actually really long time, we hope. But I think it's important to be with a doctor that you feel comfortable with, that you feel is genuine. And so sometimes it's really more personality match than anything. So I would say if you're not matching, you don't feel great at that first visit, then that means something.
That's great. Thank you. And I'm sorry, I'm just going to say poor Dr. Petrini's had a little bit of issues with her online system. So if you lose your visual sight of her, we can still hear her. So don't let that bother you guys. I know it's a little disturbing, but she can still talk to us and hear us. So we just lost you, Dr. Petrini, but I know you'll be back. But we can still
invite me back in. I know I'll be back.
Okay. So if you guys can bear with us for 1 second, I'm just going to pull her off and I'm going to bring her back in. We have found that this is what works for us. I think everybody's been able to see now with the last year we had that we all have to get a little creative with how we do these things. Okay, I'm inviting her back in. So she'll be back on in a second. So thank you, technology. There you are. It worked. Beautiful.
Excellent.
All right. So this was perfect because it gave us a chance to have some more questions come in. And that's the most important. Like, your information is always so valuable, but it's also great for people to be able to ask questions. So without further ado, one person asked, is there anything different about an initial visit for secondary infertility?
Great question. So secondary infertility is really getting more and more common. And that's often because nowadays we're having babies later. And so when you have your second baby, it's even later. And we know that one of the major factors of fertility is just advanced ovarian aging. It's like, the ovaries, want to be, you want to be still the same age and the ovaries won't let you do it, right? So anyway, the questions are basically the same because we don't want to find out that we thought it was just this simple ovarian aging, but also there's something else going on. We don't want to miss that. So a lot of the questions are exactly the same. We do a full evaluation no matter what. Sometimes people have already had part of that evaluation done, or sometimes things won't be indicated. For instance, if you've been pregnant before and you've had a normal vaginal delivery with no complications, I don't have any reason to think that your tubes are not open. So we may defer a portion of that testing, which would be the X-ray dye test for the tubes. However, if your delivery had a C-section, I might be concerned there's scar tissue that's closing the tubes off and not allowing you to get pregnant the second time. So for that person, I would still do those same things. So it really is very individualized. And we definitely want to miss steps just because we think got pregnant before. It's just an age thing, right? So we're going to look into everything, especially as your history tells us to.
That's great. Thank you so much. All right. Another question is, I have done genetics testing before at another fertility clinic. Do I have to get it done again? And also, would my husband have to get another semen test done?
Those are great questions. So oftentimes, a lot of what we do at the end of the first visit is request records. So especially if these things have been done recently, we definitely would just gather records from the clinic. And take into account. We do that a lot where we don't repeat tests if they've been done by a clinic that we know and is, reputable. For genetic testing, it's a little bit of a nuanced question because genetics are changing so rapidly, and panels that used to be testing for 100 recessive genes now can do up to 600 genes. So, talking with genetic counselors, you'll find that sometimes those extra things they're testing for are really very esoteric, like random things that you may not even want to know. So basically for genetic testing, we would see how large was the panel that you had tested, and are you interested in looking for more? And that's an individualized decision because we think that most of the genetic panels that have already been done are hitting the high yield things, but maybe there's a specific piece, again, individualized history, maybe a family history, where we want to look into even more minute things.
Thank you. All right, the questions are coming in. Let me see. I had a surgery last September that had to remove ovaries and tubes removed due to large cysts. The doctor left a small portion of one ovary. Is there a procedure to help us conceive?
So if there's a portion of your ovary left, then we would do one of these tests, the ovarian reserve test, either by looking on ultrasound or by that blood work test, and we can see how much function do you have left of the ovary. There is a chance that we could get good viable eggs from the portion of ovary that you have. And otherwise, there's not great options as far as regenerating or growing a portion of an ovary. So if that remainder of the ovary doesn't have much function left, then basically we'll be looking into things like egg donor. Would be probably the highest yield option. But we always would look to see if you are able to have your genetic child first and see what that's going to look like for you and how much medication, how much treatment you would have to undergo for that as a first option. And if that didn't answer your question, type some more specifics, please, as well. I'm happy to answer again.
Okay, thank you. If I was diagnosed with uterine abnormality, double uterus, can I have a consultation before getting pregnant to see if surgical treatment is needed?
So great question. So there's a lot of uterine abnormalities that we do treat. Sometimes we treat them surgically, but with a straight double uterus, most of the time we don't surgically correct this actually, and you can get pregnant with that abnormality. We'll maybe have you see a high-risk obstetrician, which is also called a maternal fetal medicine doctor, because they can help you understand what a pregnancy would look like with this condition. But oftentimes this doesn't even need to be fixed, and it ends up being completely a normal pregnancy. And the process that we would do to help you get pregnant is very similar to anyone without that abnormality as well.
Wonderful. What are some excluding factors when it comes to fertility, or will you treat all patients?
So yeah, I think that the answer to that is that we treat all patients. Certainly if anyone has a very serious medical condition, in other words, being pregnant would make them very sick and be a danger to their life, then we would either need to, one, optimize that medical problem before we get you pregnant, or two, potentially recommend something like a gestational carrier, where you would be able to create embryos with us and then not carry the pregnancy if that was going to make you very sick. So for the most part, it's about optimizing a medical condition, but a major medical condition would be the only thing that potentially could disqualify you from part of what we need to do. And that's just for your own health, to be the most healthy pregnancy that you can have.
We have so many questions. This is a great
We're probably
topic.
going to touch on most of the stuff I was going to talk about when tests return in the questions, so it's all good.
Yeah, everybody's learning even through all these questions. Do you do a sperm DNA fragmentation analysis?
So yes, that's definitely something we can do. We don't do it routinely. It would be as we need to by a patient's history. One of the most important things being, do you have a history of pregnancy losses, or is there a history that embryos are not growing well in the lab? If you've done prior IVF cycles and for some reason they're not growing well, say after the 3rd day, because we know that that's when the male contribution kicks into an embryo. So those are 2 scenarios in which we could do a DNA fragmentation analysis. And the reason is because we know that if we have a high DNA fragmentation, we can actually select sperm in a different way with a different type of device in the lab to select for the ones that have that are healthier, that have a lower fragmentation level, and use those to fertilize the eggs that we get. So we do test for it in specific clinical scenarios, and we can do something about it if we do find that.
Okay. We had the question about the ovaries. So there's a follow-up question. I had one ovary removed, but have the other functioning. What would the process be?
So the process is very similar. Same initial questions, the same initial workup. It would just mean that based on your individual factors, we would need to potentially create a different treatment plan. So for instance, if you have, we still want to make sure both fallopian tubes are open. If the ovary that you have, for whatever reason, is on a side where you have a blocked tube, then we might be talking about IVF. But if your fallopian tubes are open on the side that you have one ovary, we still do lower level interventions like intrauterine insemination for patients with that issue. And people can still definitely get pregnant that way. So we would definitely do the same full workup, and we would just know that maybe there is a little bit lower chance per month based on that, or a little bit lower chance of success with IVF. But all of that is not a barrier to going forward with treatments.
So you mentioned fallopian tubes, and that's one of the questions. How are proximally blocked fallopian tubes treated?
So it's a great question, and it would have to depend on how we know that they're proximally blocked. So most of the time, or a large majority of the time, if they are shown to be proximally blocked on the HSG or hysterosalpingogram Pinkogram, it can actually be a tubal spasm. So usually we can repeat an HSG and see if in fact it is persistent. And if so, there are a couple of options. One, you can try to surgically open them, which means that you do a small surgery where you go from below, you don't make any cuts anywhere, and you try to kind of put a cannula or almost like a roto-rooter through the tube. If that doesn't work, then you would be talking about IVF. IVF is kind of like the biggest gun that we have. We use it for a lot of different indications because it kind of overrides so many things and allows us to optimize in so many ways. But if we don't have to do that first, we don't really love to do that first because it is quite involved from a financial, emotional, and physical standpoint. So if we can fix them surgically, we would. But the first thing we would do is make sure that, in fact, that is the case, that they are blocked.
All right, speaking of IVF, my tubes have been tied for almost 19 years and we're wanting to try and have a child. Do you think it's too late to untie them, or would IVF be a better option?
Mm-hmm. So it's a great question. The success rates after tubal sterilization or tubal ligation varies widely. It used to be that we would say to definitely do a surgical procedure to reconnect the tubes. But that has really changed over time as the success rates of IVF have gotten better and better. So basically, IVF has gotten more successful, so we don't want to put people at risk of doing the procedure to reattach the tubes. Usually, that kind of intersects with age. So depending on your age is whether or not we would say it's worthwhile to try to open the tubes again versus whether we would do IVF. And it's good to know also that some of the reason why we don't like to necessarily reopen the tubes is because they can be at higher risk of something called an ectopic pregnancy. So an ectopic pregnancy is when a pregnancy implants in the fallopian tube. Usually in the general population, it's about 2% risk. For the reattachment of the tubes, it's about 4 to 8% risk. So we really have to weigh that risk, how much you would tolerate that risk and how much you want to avoid IVF, and talk about the success rates of IVF by age, the success rates of pregnancy after reopening the tubes by age. So it's really, I keep saying this, but it's a very individualized decision, but it is possible, and we do that at our practice. So it's depending on how motivated each patient is to have that happen. It's definitely possible. I would say the longer time from having tied the tubes is probably associated with lower success rates reopening it, but that doesn't mean it's not possible.
All right, I'm going to ask 1 or 2 more questions, and then I'm going to bring you back on to finish what you wanted to say, and then we'll finish the rest of the questions because you have so many. It's amazing. All right. After the sperm DNA fragmentation analysis, what are possible treatments of selecting the good sperm? Is it only IVF or something different?
Mm-hmm. So great question. So one of the devices that we use to select the sperm is a procedure called microfluidics. And basically it is kind of like a maze we send the sperm through. So we load the sperm in one end of a tiny little device, and inside there's a tiny maze. This sounds like I'm making it up, but it's real. And the sperm that have lower DNA fragmentation are the ones that are going to be able to make it through this, and that we ultimately will select out of that because of the way that they differentially swim. So that's actually really good to use alongside something called IVF, because once we have those sperm, it may be a lower count. So we may not get that many that have proven themselves to be good through that device. And therefore, if we do IVF, we need less sperm. So the number of sperm we need to have a successful fertilization with IVF is way lower than something we would want for an IUI count. For an intrauterine insemination, we want at least 10 million motile sperm to be able to live inside the uterus. And with IVF, we only need 1 sperm per egg, because we can basically pick up 1 sperm and inject it directly into an egg. So sometimes if people have a low starting count in addition to high DNA fragmentation, we would still want to do IVF, but it is usable with IUI in certain cases.
Okay, thank you. All right, we lost your video again, so I'm going to close you out and bring you back. Yeah. Sorry, folks, technical issues, but we are going to get to all of your questions, so or as many as we can. So let me just bring Dr. Petrini back on. Oh, there we go. Sorry. She will be right back. There you are. And I will disappear until you finish your next segment, and we will ask some more questions. So I'll see you in a few.
Great. So not too much more to talk about. Basically, I wanted to kind of go through some of the things that we would expect from some of this blood work and how that would lead us to a treatment plan. So some of the, sorry, not just blood work, some of this initial workup. And we covered a little bit of this in you guys' questions. So thanks for asking those. So initially blood work, for instance, that is going to give us information on your thyroid, on your ovarian reserve, and potentially some factors that could cause things like recurrent pregnancy loss or irregular periods. So for instance, the AMH level, I like to talk about it because it's one of the most poorly understood fertility tests that we do. The AMH level, or anti-Mullerian hormone, is often sent by your OBGYN, and you might have a number back that you feel like it's high or you feel like it's low. It's important to know that actually that number The general population does not tell us whether or not you can get pregnant. It doesn't tell us whether or not you can have a baby. As you've been hearing, there's so many factors that play into that. So really all it tells us is if we need to intervene, if we need to give you medication, how much medication do we need to give you, and what would the process look like for you from that standpoint? How successful can we be with something like IVF? It doesn't tell us whether you can get pregnant or not. So I always like to talk about that because I think that people, if they get a low number, it's very scared, but it actually does not tell you if things are not going to go well necessarily. So I like to just clear that up a little bit. The other things we get back, things like your thyroid level, if there's an issue with that, it's very easy to intervene. Usually we just do a small dose of thyroid medication. Importantly, the number we want for thyroid in pregnancy is actually lower than the general population. So if the number we may be not even that if you were to have a level that we said we wanted to intervene on. Did you lose me again?
I still saw you, but you sounded like a robot. So,
okay.
But now that I'm back, you sound better. So I'm just going to stay here and
listen. Great. So we're looking at the thyroid level, and we also are looking at something called prolactin. Sometimes when people have menstrual irregularities, it can actually be a sign of pituitary disease. And so we look at that level to make sure that that's normal. In addition, if we send blood work for recurrent pregnancy loss and any of it's abnormal, we can easily treat with blood thinners in pregnancy and early pregnancy before you even know you're pregnant to try to prevent a loss. So all of these things are actionable, and that's why we're sending all these tests. And then, same thing with the other tests we do. The ultrasound in the office, if we find fibroids, if we find polyps, we would probably do a small surgery before we would try to get you pregnant, and that would increase your chances. With the semen analysis, depending on the levels that we get, that could mean we think it's okay for you to continue trying naturally, or we might want to optimize with something called an intrauterine insemination, which allows us to concentrate sperm and give you just the highest yield amount of sperm directly into the uterus. And in rare cases, if there's very little sperm or no sperm at all, that might prompt an infertility evaluation for the male partner, where we would either send blood work or we might send the partner to a urologist to do a full exam, which I know sounds scary for the male partners, but it's definitely something important because, again, if they find something, they may be able to optimize so that you would kind of downgrade from needing IVF to needing something lower level like an IUI. So in all of this, we're just trying to find things that we can optimize. And then I guess finally with the fallopian tube dye test, we've talked a little bit about that already, but if we do find blockages, potentially we can surgically change that, or we do a process like IVF where we don't need the tubes at all. So I guess I can just answer more questions that
Sure.
you specifically want to know.
Yeah. Okay. Let's see. How do I? All right. I'm just going to stay small here. All right. Would tests done in April this year still be recent? And that was from a female. And then I'm going to combine that with another question that had to do with a semen analysis done 2 years ago. Was that too far out, and do they have to retest?
So yes and yes. So for tests done in April, female fertility tests, that would definitely be recent. Usually for most of these things, we like to see them done in the last year. So April would definitely be reasonable unless there's a major change in health or other status during that time. And then for the semen analysis, generally same rule. We would like it to be within a year. Just because we know that it takes 81 days or approximately 3 months for sperm to turn over. So changes can definitely happen within that 2-year period that we'd want to know about. And again, all of these tests whenever I see new patients, we'll talk about every single one of these tests, but it's always the patient's option to say that they don't want to repeat it. For instance, the X-ray dye test for the fallopian tubes can sometimes be a scary test for people because it causes a lot of cramping, and people have probably talked to their friends about horror stories about this test. So obviously, if people have a reason that they don't want to be redoing it, we talk about what would it mean if, you started treatment and we didn't have this information and we found it out later. So we can always defer tests based on the patient's wishes as well.
That's good to know. Do you recommend starting any supplements for infertility before the visit? And if so, which ones? And if not, why not?
So that's a great question that I get all the time. There are lots of people who take different supplements, and there are a lot of supplements that you can read about. I think two of the most common ones are DHEA and CoQ10. And these supplements people have talked about, can they improve the egg quality? There's whole books on egg quality and whether or not different interventions can improve quality. And by and large, most of these things have not been really well studied in a way that we know definitively that they do. So my kind of counseling that I tell everyone on these things is it definitely does not hurt. These are just vitamins, CoQ10 and DHEA. So I don't recommend that people necessarily take them because I think it's extra stuff to do, but it definitely does not hurt. So it's more just, are you someone who feels good about taking the vitamins, knowing that you might be helping? Or are you someone who's going to be stressed out by taking an extra medication each day and blame yourself if you are not taking it and thinking that you did something wrong for your egg quality? I really don't believe that it makes so much a difference that people should stress out about doing these things. And the research really hasn't shown that they definitively do. It's a hard question to answer because I wish there was a magic bullet and I wish there was a vitamin that I could say this really helps, but the data is actually really mixed on those things. The one thing that I do recommend that everyone be on is a prenatal vitamin. And this is important because we know that folic acid, which helps prevent neural tube defects, things like spina bifida, is most important to be on board 1 to 3 months prior to conceiving. So if you're thinking about having a child, you should be on a prenatal vitamin or at least folic acid, 400 micrograms a day minimum prior to conceiving.
I never knew that. That's amazing. Thank you for sharing that. Good thing my kids turned out okay. All right.
You probably had it in your diet. Most people do, but just in case.
Yeah, that's amazing. Okay. Do you have additional testing for the MTHFR C677 single mutation?
So we can test for MTHFR. Generally, it's part of a workup for recurrent pregnancy loss because it falls into the category of disorders with clotting. So we would test for that. And if so, we would also look for levels can guide us as to whether that MTHFR mutation is relevant to causing pregnancy loss.
I had a hysterosalpingogram. I can't believe somebody made me say that word in May of last year. Luckily, I've heard all of you guys say it a few times. Did I say it okay? Mm-hmm. Hysterosalpingogram in May of last year. Would that still be valid?
So May, I have to remember what month we're in.
August. Yeah.
I would again say, we like to have it within a year. But again, that's kind of on the borderline where, depending on what we're concerned about, repeating it or not repeating is a discussion that we would have together. If there's something else that comes up in the history or other workup that's more obvious as to why you're not getting pregnant, then I don't feel as strongly about repeating a test, especially if you're very adverse to it. But it is like more of a complete workup. So we like to have these within a year, but it's also individualized based on what we're finding otherwise in your evaluation.
Thank you. All right. Egg freezing question. If I'm not ready to get pregnant now, but I'm concerned about my ability to get pregnant in the future, I have low AMH. Is egg freezing something you would recommend exploring? And what is the egg freezing typical cost? And I know that might be a hard question to answer.
Yeah. I would always say egg freezing is worth exploring, with the caveat that, we don't, I don't like to tell people that it's an insurance policy because nothing is 100%. Even if we get, 50 or 100 eggs, we know that our rate of kind of guaranteed child with that still just approaches 100%. We can never say 100%, right? But it's always good to think about these things. And especially with the cost question, if you have coverage for egg freezing, then I think it's a no-brainer. But also most women that freeze their eggs don't actually end up using them. So it's a good backup plan. It's not an insurance policy, but it's definitely something that I think gives a lot of people peace of mind and helps them live their lives kind of more freely, knowing that they have this option. So the process of egg freezing is very similar to IVF as far as its involvement with, the medications you give. The basic workup, if you need to do egg freezing, is more minimal than what I spoke about before. It's not as inclusive. There's way less that needs to be done, basically just a blood test and an ultrasound. And then once you get your eggs after the retrieval, you don't have to worry about fertilization. You don't have to worry about what embryos make it. We just freeze the eggs and they're there forever. They outlast us. They last basically infinitely. So I think it's something that more and more people are doing. We're getting more and more information about, and I would definitely support it. But as far as the cost, that's a huge concern, and it really depends on insurance. But it's generally less than IVF for infertility because you don't have the male component that needs to be evaluated. There's less embryology because you don't have to fertilize or watch embryos grow in the lab.
Yeah, there's a lot on egg freezing now that's out there that's amazing. So it's so wonderful. It's an option, especially for women that are career oriented and don't want to start families right away. Speaking of, so one of the questions is, at age 42, I've never been a mom. I did IUI and want to go straight to IVF. Is this possible?
Yes, it's definitely possible. And honestly, I think most of the time, if you're amenable to doing IVF, that would be a great option to go straight into it at age 42, because we know that that is the highest yield intervention that we have to offer. And we definitely don't want to waste any time. So IVF is definitely available to do straight. We don't have to do IUI first for anyone. If people want to go straight to IVF, based on their family planning goals, then we would do that for anyone. For instance, maybe if you're not 42, but maybe if you're 35 and you said, I want 4 children, then IVF would be a good option, because then every embryo we get from you, it will be from age 35. So when you come back at 45 to have that 4th or 5th child, you don't have to worry about going through IVF at that point in your life when it might be harder and lower yield.
And one more question, which is perfect timing because we're getting to the end of our session. How is InvoCell different from IVF, and what are the success rates between the two of them?
Mm-hmm. So InvoCell is something that's, I would say, fairly new. But the difference is, after the process of doing the injection medications where we stimulate the ovaries to create eggs, we fertilize them just like we would for IVF. But instead of watching them in the lab, we actually put them back in a device that would basically be an incubator in your own body. And so the difference is that we actually have like a little bit less, I would say a lot less control and understanding of what those embryos are doing as they grow. So it's a generally thought to be lower cost option, but I would say it's not quite proven out yet as far as recommending it to people widely. I would still say that IVF is still the most proven and understood way of doing things.
All right, do you have time for one more question?
Yes.
What tests would an egg donor need to determine their eggs' quality and quantity?
Mm-hmm. So very similar to anyone wanting to know their egg quality and quantity. The caveat being that we can't actually ever directly test egg quality. So egg quantity comes back to that AMH level, or ovarian reserve anti-Mullerian hormone. And that tells us how many eggs we can expect to get from a cycle. The best way really to know about quality is to see how these eggs do in the lab, whether they can create good-looking embryos, whether they can create viable pregnancies. So there's not a great way to tell if a donor has good quality. The number one thing related to quality outside of seeing how they do in our lab is just age. So that's why generally most egg donors are younger, just because as we age, the egg has a harder and harder time correcting genetic abnormalities. And so younger eggs will have less genetic abnormalities. So quantity is easy to kind of figure it out based on that blood test and an ultrasound looking at the ovaries directly. But quality is very hard to determine. We know directly it is related to age, though.
Well, Dr. Petrini, thank you so much for the amazing information. Thank you for your time. I just want to remind everybody that they can get more information at txfertility.com, that these sessions are the third Thursday of every month. And it's always, there are several topics on Fertility 101, but sometimes there might be a session on egg freezing or PCOS or male infertility. So invite you to check out the website. And thank you again so much, Dr. Petrini, for your time. I will increase your screen in case you have any last remarks you want to make before we close out.
Yeah, I just want to thank everyone for joining, and just want to say that I hope that this was super helpful so that when you're walking into the clinic, you know what to expect, because I think that's the hardest part about walking in, is really not knowing what it's going to be like. And hopefully this will help more people address their goal of helping build their family now or in the future.
Amazing. Thank you so much. Good night, everybody.
Thank you.